we're all working in very pressurised healthcare environments where there is a real premium on bed availability. And if we're offering what is essentially a new service in terms of venous intervention, it's been around for years now, but we're looking to grow it, we need to find cost-effective and efficient solutions to treating these patients. That means minimising our impact on the ITU, HDU beds, minimising patient length of stay, and mechanical thrombectomy allows us to treat these patients in a single sitting, and in a majority of cases, if we are offering an effective mechanical thrombectomy solution, we can treat these patients in a day, and all this has a positive impact on our how we impact on the healthcare systems. The second reason, I think, is obviously these are typically young patients. We want to remove the risks from thrombolytic therapy. You know, this is, although small, potentially catastrophic. We always think about the risk of intracranial hemorrhage, but there are other multiple, bleeding issues that can occur in terms of access site, genitourinary, gastrointestinal. And not only do we have the morbidity from these bleeding complications, if we have a bleeding issue, our treatment options are significantly impaired following this, in that we basically have to withdraw all treatment once we have a bleeding complication. So we want to avoid that. The other reason, I think we always look upon thrombolysis with sort of rose-tinted spectacles slightly, in that it was an effective solution. In acute clot, it may be, but the majority of the patients we see are not presenting to us in that acute phase where we're treating acute thrombus. A lot of patients, for a multitude of reasons, present late, where the thrombus is more organised. Thrombolytic is not as effective in these patients, and we need an effective mechanical solution that can treat this more organised thrombus. As thrombus develops, so acute thrombus we know is typically composed of red blood cells, platelets. By about 7 days, fibrin deposition is complete, and fibrin is our target, or traditionally was our target, for thrombolytic. After that, we start to get collagen deposition, which is, what makes the thrombus more organised. And that is the thing that typically isn't responsive to thrombolytic therapy. So that is why we need, I think, in those patients who have the more organised, let's say lytic-resistant thrombus, we need an effective mechanical solution that can clear that more organised thrombus. In our Oxford data, our median thrombus age, based on physician assessment through history and things like that, is 14 days. So if we're looking at our more traditional therapies, thrombolytic, other thrombectomy devices, we always used to say at 2 weeks, things become less effective as the thrombus becomes organised. But our data has shown that we're able to treat these patients with more subacute thrombus effectively with the device. So I think it does show that it's effective on the range of thrombus from hyperacute clot up to more organised thrombus in terms of our thrombus removal, and our data bears that out. There are multiple reasons. I think one is still a lack of awareness amongst the medical profession about the options we have. Even in your own hospital and in your own specialties, people still think we're thrombolysing patients. A lot of people don't present in an acute manner because often they will opt for the conservative treatment until they realise that they're not improving, and at that point we're looking for intervention. Again, the referral pathways, they need to be streamlined. You need to have an effective solution to get the patients to the correct person in a timely manner. I think we've addressed that in Oxford in that we've developed a very effective online referral system. So we are, again, even with that, we're still getting patients slightly late, but we'd rather have them referred to us so we can deal with them. And the main advantage now is we have solutions where if there is an issue in delayed referral, we can still, treat them effectively. And the final thing is, alluding to the earlier point about the pressurised healthcare environment, we still have issues with being able to perform the cases on these patients in terms of theatre availability, whether we can get the patients into hospital, and that often results in delayed treatments because, if we can't operate on the patient for another week, the thrombus has aged in that period, but we're still able to treat them. If clot doesn't clear, what happens is essentially you get venous wall damage, you get fibrosis, you get venous obstruction, all of which contribute to venous hypertension, which is the principal pathology behind post-thrombotic syndrome, and that's what we're trying to avoid. If we have an open vein, we reduce our likelihood of venous hypertension, and then we're aiming to prevent PTS by stopping that developing.